I'll be presenting my talk, which is the next, and which is basically a diagnostic vitreous biopsy in patients of uveitis. Basically, posterior intermediate or panuveitis of an unknown cause is the situation where a clinical examination or laboratory investigations have failed to draw a conclusion on the diagnosis. Is the time when we'll think of taking a sample from the vitreous, or there is a strong suspicion of intraocular malignancy like a masquerade, or a potentially sight-threatening acute uveitis with a negative non-invasive laboratory and ancillary investigations, or sometimes when you have a very atypical presentation of uveitis and you're not sure what you are dealing with. These are a whole lot of infectious and non-infectious uveitis indications where you may opt for doing a vitreous sampling. As far as the pre-op preparation is concerned, we have to do a detailed clinical history. There are no shortcuts for that. A complete ocular and physical examination in any patient of uveitis, along with relevant ancillary laboratory investigations, are a must. We must also have a list of differential diagnoses rather than doing anything very blindly. A plan by the uveitis expert about what tests to be done after the sample has been collected is it has to be well outlined before you actually plunge into collecting the sample. We have to also inform the microbiologist and pathologist to be ready in their labs to be receiving the sample. And also it's a good idea to have a word with them to exactly know how they want the samples to be packed and how they want them to be sent to them. Even though it's a vitreous biopsy, an informed consent is essential because it is an intraocular procedure, and we have to counsel the patient very properly, because many a times they think that you are doing it for a therapeutic purpose, while it is basically being done only for a diagnostic purpose. Certain tips for vitreous sampling: you have to collect an undiluted sample as far as possible. So you should not put on the infusion at the start of collection of the sample. And if your eye starts becoming hypotenuse, then you can use an air infusion, which is going to avoid the dilution of the sample. For intraocular lymphomas, if that is your clinical suspicion, then it's best to stop the oral steroids 2 weeks prior to the sampling. The lab is informed of the sample collection and sample coming to their labs, because these cells are extremely fragile, and the sample has to be sent to the lab as early as possible. A low cut rate is used, as low as 600, and all vitreous sample, including the cassette, has to be sent to the lab. Preferably, in most of the situations, the plating should be done preferably in the operation theater. Now, these are the various diagnostic tests which can be performed on the sample which is going to be collected, and we should be very clear in our mind what tests are we exactly looking for. So this is just a quick replay again of what Dr. Sangeet has already shown. So this is just the cutter. So we are just detaching the aspiration line, and we would be now attaching this aspiration port to a syringe. And once you have taken the cutter inside the eye and you have started actively cutting the vitreous, the assistant can gradually collect the sample inside this syringe. So after you have actually collected the sample, you see this yellowish vitreous sample coming into the syringe. You can put on your infusion line. It's always a good idea to expel out all the air which is there within the syringe. Put a needle on top and rotate the needle to avoid any kind of contamination into the sample. You finally cover up the syringe and the needle. And put it in a sterile pack, which is sealed with proper labeling with the name of the patient and the diagnosis. It's always a good idea, if you can arrange, to inoculate the sample in the operation theater itself. So you see all the culture plates and the various medias. You are having it in the operation theater, and I think this is the best way of inoculating your sample, which would avoid the least of the contamination to your sample. Now, this is just an example of an 18-year-old boy from Bihar who had a gradual painless diminution of vision in the left eye for last 6 months. There was no significant systemic history or a contact history with the low socioeconomic status. This is how he looked in his left eye, where he had this huge subretinal yellowish mass in the macular area with subretinal fluid. And there was this mottled appearance on a fundus fluorescein angiography with a hot disc. So we were very sure we were dealing with some inflammatory pathology. We did an ultrasound, which was also not very conclusive. And the provisional diagnosis in our mind was a subretinal abscess, possibly a tubercular etiology, a fungal, and very rarely a lymphoproliferative disorder. The CECT of the chest also did not really add to our diagnosis, but something alarming was there, that the Mantux was 0 in this particular child. And what was suggested by the pediatrician, that either the child was immunocompromised or he was suffering from some chronic infection. So what we did in this child, we went ahead and did a vitreous biopsy because we were not sure what we were dealing with. It's always a good idea, if the media clarity is there, then to go as close to the lesion and collect the sample just above the lesion that you want a diagnosis to be made of. The vitreous biopsy was sent and cultured on various plates. And to our surprise, this child actually was diagnosed to have nocardia infection in the eye. MRI brain was done to rule out intracranial nocardiosis, and the patient was started on the suggested treatment for nocardia along with oral steroids. And you see that there was a beautiful response with resolution of subretinal fluid, regression of the lesion, and the patient recovered a good vision of 6/18 and 12. Well, vitreous biopsy also doesn't go without complication. There's always a risk of retinal break and retinal detachment. You can also have intraoperative or postoperative bleeding. There can also be a transient hypotony, especially if you are doing a sutureless MIVS technique for collection of the vitreous samples. So I would just conclude by saying that whenever in doubt and not able to confirm the diagnosis, or you have a very poor response or no response to the treatment, then vitreous sample is a good idea in uveitis patients. A preoperative ancillary testing to the best of you, such as all the investigations available like angiography, OCT, ultrasound, and UBM, they should all be done before planning an interventional diagnostic procedure. A clear plan by the ophthalmologist is essential with preparation of the lab personnel, the microbiologist, and the pathologist, and they should exactly be made aware of the sample being sent and what exactly you're looking for. There is no need to control the inflammation prior to a diagnostic vitrectomy because you are actually wanting a sample in hand which can add to the diagnosis of the patient, and then subsequently you can modify the management of the patient. So thank you once again for your patient listening.